lecture. It has like everything about ADHD and then medications at the end. And we've always tried to rush through the first half to get to medications because that's what you guys really wanted to know about. So now we have two different lectures. So you just got the medications lecture not that long ago, and it's coming again. So don't worry if you didn't get it. So this one is mostly about like the background of ADHD and theory of ADHD, but it's shorter so that if we finish all the slides, then we can still talk about medications, because I know that's what you guys probably really want to hear about. But they test you on this other stuff too. So we should probably do both. So we are talking about ADHD, quite obviously. Now the slides move. So no conflicts of interest, but whenever we talk about ADHD, we're pretty much guaranteed to talk about off-label use of medications, just because of how the FDA approves these meds, and that they're only approved for the most part for 6 and up, and we treat people who are less than 6. So I will point that out at the time that we talk about them if we end up talking about them. So our learning objectives are about epidemiology. We're going to look at the neurochemical basis for ADHD, really exciting, and diagnostic criteria, developing an evaluation plan, looking at comorbidities, and then looking at long-term outcomes of ADHD. And if we have some time at the end, we'll talk about medications and do just kind of like questions that you guys have about ADHD meds, because that seems like that's where we usually end up spending a lot of our time. So epidemiology of ADHD. So worldwide prevalence, no matter what people say, that ADHD only exists in America, they're wrong. Worldwide prevalence is 7.2%. Everybody always seems to cite France as having really low rates of ADHD. Theirs is actually slightly higher than America's rate of ADHD. So just, I know, so everybody has ADHD. Every country's got ADHD in it. In the United States, our most recent numbers were 2016, and 8.4% of kids ages 2 to 17 had a current diagnosis. 9.2% have ever had a diagnosis in that same age range. Not really sure where their diagnoses went. They probably got switched to some other psychiatric illness, would be my guess. That accounts, though, for 5.4 million kids at any kind of given moment in America have an ADHD diagnosis. So it's a huge group of kids. So this is definitely something you all are going to see. I don't think I have to convince any of y'all that y'all are going to see ADHD, because you all are going to. Doesn't even matter if you're not in primary care, because you're going to see these kids on the wards, you're going to see them everywhere. And so you kind of have to get some skills about how to manage their ADHD, and if somebody else is managing it, like when you need to hold meds or what the meds could do, how they could be contributing to some of the other things you may be evaluating them for in the other subspecialties. Diagnosis, so the median age of diagnosis is 7 years old. A third now are diagnosed prior to 6. So it's actually a really big number. It just keeps increasing. So we're getting earlier and earlier diagnosis. We're getting more and more of those preschool kids who are kind of off the chain. That's the only way that they come to recognition, is that their hyperactivity is so high, even at those younger ages. A lot of kids now, a lot more 5-year-olds are getting diagnosed, and particularly coming to us. And we'll talk about those kids at the end. Over 50% are diagnosed by primary care. So we know it's a big primary care issue. We'll look at what the recommendations are about primary care's role in diagnosing ADHD in a few slides. And then treatment-wise, just as an overview, about 2/3 of kids with ADHD, so about 2/3 of that 5.4 million kids are currently on medication. Only half have ever received behavioral therapy. And we'll talk about what the recommendations are around that and why those two numbers should not be so different as they are. And then about a quarter have never received any treatment for their ADHD of any kind. So not behavioral therapy nor medication. So when we're looking at this problem, when we see any group that has such a huge prevalence, any diagnosis, then we kind of want to know, why are we seeing so much? How are we getting so much ADHD? It's mostly inherited, is really the truth. So this chart just shows you like kind of some common things that we think about as being inherited. I know it's kind of small, but where I want you to really look is kind of like right around this kid who's holding the little DNA helix. So these yellow bars right above his head are, let's see, macular degeneration, age-related macular degeneration, type 1 diabetes, and Alzheimer's disease. That's the area where ADHD sits. So 77 to 88% heritability. So genetics explains about 80% of all ADHD cases. That's really big. So if you have a family where you've got two parents with ADHD and they like come to you for like their newborn visit, you should immediately see that history and think, okay, so I'm going to be watching for this at your well child checks, because the likelihood that that kid's going to develop ADHD is just really, really high. It's almost a given. So it lets you kind of clue into when you see that history, which you should be watching for preemptively in those kids. The genetics of ADHD are, like most things in developmental peds, really complex and multifactorial. So there's so many genes associated with ADHD that it really ends up not being clinically helpful or useful to us. So we don't do any genetic testing looking for ADHD. The only reason I put some specific genes on here is not for you to memorize them, but just more so because we're going to look at the brain and how ADHD is working in the brain and why these genes are specifically interesting. So we've got two dopamine genes, one for a dopamine receptor, one for a dopamine transport. So you can think, ooh, I wonder if dopamine has a role in ADHD. That would be a good thought to have. And then there are also some that have to do with structural areas of the brain. So this GFOD1 is only expressed in your frontal cortex. So we'll look at what role does the frontal cortex have in ADHD. And then there are a bunch of genes that are associated with other neurodevelopmental disabilities. And that's part of the reason why chasing down genes for ADHD is not super helpful, kind of like you hear us talk about sometimes for the majority of our kids with autism, because these genes that are associated with like everything. So for instance, the CHD13 gene is associated with learning issues, autism, bipolar, schizophrenia, ADHD, like so many things. So it's not really helpful to a parent to be like, oh yeah, your kid has this gene and they could have any psychiatric illness that we've ever learned about. Not super helpful. Also not very diagnostically helpful, right? Because it's not like that's going to confirm your ADHD. So no specific genetic pattern, not really helpful for us. But the neuroanatomy of ADHD, every so often this sneaks onto your boards. And so we had not previously covered this very well. So since we've started seeing some more of these questions kind of popping up in board reviews and stuff, I thought we would go ahead and look. So the areas of the brain involved in ADHD, frontal lobe, specifically your prefrontal cortex, that area of your brain really works to filter out distractions. Sometimes you'll hear us mention in developmental peds executive function, which are all these like higher level thinking processes. Those are all coming out of that frontal lobe. This is like where you get your that go or no go response. Like, should I not do this impulsive thing? Should I hold back on it? Also where you get all your organization and planning. So you can be a really smart person and have really poor executive functioning, and you'll be very impaired, even though you're super bright, because you're lacking a lot of these higher order thinking patterns that are coming out of that frontal cortex. Executive functioning is a really huge impairment in kids with ADHD, and it's mostly coming from this frontal lobe impairment. Your basal ganglia, if you start thinking about dopamine, you should start kind of thinking the basal ganglia might be involved. And there we see a lot of inhibiting autonomic responses. So some of that really quick escalation that our kids with ADHD do, that's why we're kind of looking at dopamine and looking to affect dopamine and helping dopamine have a bigger role and a bigger play in those kids to help regulate some of that. And then lastly is the cerebellar vermis, which regulates motivation. I wish we had any medication that could target this area of the brain, but we don't. So that's why you hear us talk a lot about how I can treat your ADHD symptoms, but none of my meds will help with motivation. We know that motivation is affected in people with ADHD, and we really don't have any way to target that. So we'll talk about some of the interventions that we can do behaviorally to help with that toward the end of the lecture. So neurochemistry, not to harp on dopamine, but if you ever had a question and it was asking a neurotransmitter and ADHD, this one that's in bold with a bunch of red behind it would be a really good one to look at. So we usually think about dopamine and norepinephrine as having a role. The role that dopamine plays in ADHD is just a lot more fully elucidated. We have more research about it. We just understand it a little bit better. So that's usually the one you want to answer. So we know there are a couple of dopamine, like the receptors, the transporter, are all affected by dopamine. We think our stimulants have an effect on dopamine. And we looked at the neuroanatomy of the brain. You've got that basal ganglia to do with dopamine. So you hear this dopamine, dopamine, dopamine. Sometimes they'll ask you about that. What dopamine's doing though, is it's enhancing the signals in your brain to help you focus. So it's trying to help you see the things that are important and to focus you on those, while at the same time improving your attention in those tasks. So you can have a lot of great thought and you could be thinking in 40 directions at once. But this is going to help you think deeply and well about the one thing. So we're focusing all of our attention to the task we should be doing or the line of thought we should be on. It plays a role in executive functioning, like we've talked about. So you see this mesocortical pathway, and you see how a bunch of those pathways are ending in that frontal lobe. So we know it's probably going to have some executive functioning role. Sustaining and focusing attention, like we talked about, and then modulating behavior based on social cues. So that's a really big thing that in developmental peds, most of our kids have an impairment with in one way or another. And this is the way that our kids with ADHD struggle with social skills. This idea of picking up on on a social cue and then adjusting our behavior to match, which is kind of hard to do, especially if you're not paying attention to them. Lastly is this norepinephrine. Like I said, this is not a wrong answer. It just oftentimes on a test may not be your best answer. They will rarely would give you a choice between the two though. But if you got a choice between the two, go dopamine. Norepinephrine, we think dampens all that background noise. So instead of working to focus you like we think dopamine's playing a role, this is more trying to eliminate distractions around you. It's like all that noise in your brain, trying to quiet that down so you can focus on the thing you need to be focused on. It enhances executive operations. Again, you see it working in that frontal lobe, and it increases inhibition. So it's kind of a check, a filter to kind of keep that impulsivity at bay. We think. So that was the neuroanatomy, neurochemistry part. Now we'll shift into a little more practical. We're going to look at the AAP guidelines, and then we'll briefly look at the SDBP guidelines. The SDBP is the Society for Developmental and Behavioral Pediatrics, and they have a complex ADHD guideline. So the AAP's guideline tells you exactly who it applies to, what ages, and what circumstances. And then the SDBP guideline picks up everybody who doesn't fit in that guideline and says, these are who the subspecialists see, and we have separate guidelines for them. So, as with all guidelines, it has these key action statements. So all of the, I didn't signal those as key action statements, but they're all in here. So more or less, after you go through these slides, it should kind of mimic if you had read through the guidelines, which, as you guys know, or maybe don't know, but hopefully do, the Board of Pediatrics loves to test on AAP guidelines. It's one of their favorite things to do. So especially ones that are core to Gen Peds, like ADHD is. So they love any of these points. They would love to give you a question on. So the first is that the PCP should initiate evaluation. So this is one of our kind of pet peeves in developmental peds, is a referral for ADHD when you've done absolutely nothing to work up ADHD. So we are not the primary evaluators for ADHD. That actually is completely in the hands of the general pediatricians. It's well in your wheelhouse, you wouldn't send every ear infection to ENT. It's like that kind of a thing. So any child between 4 and 17 who comes into your office as a general pediatrician who has an academic or a behavioral problem and is showing any symptoms of ADHD, the AAP says you guys start that you initiate that evaluation. You guys go ahead and start evaluating them for ADHD. So then the first step of that is making sure that they even meet the criteria for ADHD. So we always talk about, 2 locations, 2 raters. I think we a lot of times get really hung up on having questionnaires from like the parent and the teacher. You'll probably already have realized that practically it's very hard to get your hands on those questionnaires sometimes. Like grandma brought them, she only has them on Tuesdays, and she doesn't really feel comfortable filling it out and can't track the teacher down. You actually could have a conversation with 2 different people. So if you really were eager, you could call and actually talk to the teacher on the phone. Sometimes my families will call the teacher right there in the office. I don't even know. And then I'm talking to them on the phone. That counts. I don't have to go and get a Vanderbilt form from that person. I took a history from that person who's from a second setting. Or like if the teacher writes you a note. So yes, Vanderbilt forms are great because they're convenient. They have all the symptoms on there. You can score it. It's very nice and easy. But you really just have to get a history in more than one location, 2 different raters that these symptoms are present. So then we say, what are these symptoms, right? So ADHD has 2 core areas, inattention and then the hyperactivity impulsivity part. You have to have 6 or more, so at least 6 of the 9 to show that you have a clinical level of these different symptoms, and they need to be manifested as often, at least often, so not once in a while, not sometimes, often or very often. And you see that that's exactly how the Vanderbilt form is written, right? So we've got, those are the categories. So there you're looking for 2s and 3s. If y'all remember the Vanderbilt forms, that's often or very often. But they're inattention, making careless mistakes, difficulty sustaining attention, not listening, or seeming to not listen, failing to finish tasks, difficulty with organization, avoiding tasks that require sustained attention, that's a big one, losing things, easily distracted, or forgetful. There's also a component of very often or often compared to one's peers, right? So I have an 8-year-old son, and sometimes he meets all of these criteria, but like I said, it's sometimes, right? Like some days he's on it, and then other days he's all over the place. So that's why it's really important to get that good history, because otherwise you'll go running around calling every 8-year-old as a kid with ADHD, because some of that is just kind of developmentally appropriate. Like 8-year-olds do forget their code everywhere. It doesn't necessarily mean that they're often forgetful. It means they cannot keep track of a code. And that is like a kind of a typical 8-year-old thing. So that's where the questionnaires do become helpful over the history, because it's giving you a more standardized scale to look at it. So if you have any question based on history, then that's when you really do want to go ahead and get those questionnaires. So hyperactivity and impulsivity, same rules apply, 6 or more, often or very often. Fidgety, unable to stay seated, inappropriate running, climbing. Restlessness is for adolescents. So sometimes they'll sit just fine, but they feel restless. And they'll tell you, I feel like I just need to move, but I know I have to sit still in the class. Difficulty in engaging in leisure activities that are quiet, being always on the go or like driven like a machine, talks excessively. And then for impulsivity, there's blurting out answers before the question's finished, difficulty waiting your turn and interrupting. Like in conversation, or this intruding on other people is like way up in people's personal space. We've probably all felt that with a kid in the office who has ADHD. And then there are the 3 main subtypes. So predominantly inattention, predominantly with hyperactivity and impulsivity, and then combined type. Combined type is the most common. And then just to finish out the DSM-5 criteria, earliest symptoms have to be present by 12. That will become important in a minute too, why 12 is what we do if they come to you at 13 instead of 12. Symptoms have to be present in 2 or more settings. There has to be clear evidence of impairment. So what I mean is that if you are getting straight A's, you do 3 different extracurricular events, nobody complains that you are impaired in those places. You're like on the football team and you can keep track of all the plays. And you go to a high-powered private school. So the questionnaires that we get say that you're really inattentive, but then we look at your life and your life is perfectly functioning. We might say that people are holding you to an expectation that is unfair. And so sometimes we get into these traps at times with some of our really high-powered private schools where their expectation is so high and so far above what's developmentally appropriate, that they start like calling everybody ADHD, and you'll end up with private schools where everybody's on a stimulant. These real high performers and everybody's on Adderall. So that's not what we're trying to do. We're actually trying to catch the kids who are impaired, and we're trying to help them overcome their impairment. So if we're not impaired by the symptoms, then you don't meet the criteria for ADHD. And then lastly, that symptoms can't be accounted for by another disorder. That comes into play sometimes with other neurodevelopmental disabilities, particularly so intellectual disability or multiple learning disabilities, which I know y'all talked about earlier this week, or autism, also that y'all talked about earlier this week. So the next key action statement from the AAP is that you screen for comorbidities. Some interesting things is that although ADHD is more common in boys, so it's a 2-to-1 male predominance, girls have a higher rate of ADHD with comorbidity. So girls actually have a higher rate of complex ADHD. Just a quick note about the 2-to-1 predominance. When I was a resident, it was 4-to-1 male to female predominance. I mean, I'm old, I'm not that old. So in like 15 years, it's shifted hugely. And it really is because we realized we had a massive diagnostic bias. That like inattentive girl staring off, people would just kind of look at her and be like, oh, well, she's pretty, so that's okay. And nobody would diagnose her ADHD. And so I think that as there's been a lot more movement also towards like women being in like STEM careers, all of a sudden now people are paying attention to like the little girl in math who is smart at math, but never gets the worksheet finished. And so we're starting to have better time diagnosing kids across the board. So who knows, maybe someday it will end up being 1-to-1, I don't know, but it's 2-to-1 right now. I like to group the comorbidities into a few different groups. So like emotional, so those are gonna be mostly like your mood things, so depression, anxiety, some ODD, conduct disorder, and then substance abuse. Developmental comorbidities, autism, and then the learning disabilities. Particularly, and then physical, sleep apnea, tics, and seizures. So these are the things that we want to just be making sure that we're ruling out. Board questions love to present you a kid with ADHD or who looks like they have ADHD and then sneakily put one of these things, a little bit of history of one of these things in there to see if you will go ahead and evaluate that before you give the ADHD diagnosis. So for instance, if you have a kid who you're evaluating for ADHD and they also look like they have like all the symptoms of Tourette's, they do want you to evaluate for Tourette's first before you call this ADHD. Same thing if they're staring off and you think, you know, they're staring off and sometimes if you tap them on the shoulder, they still don't respond. We need an EEG on that to make sure that's not an absence seizure before we give the ADHD diagnosis. So they'll try to trick you up on those. And that's kind of one of the ways that they like to test on comorbidities, to make sure you guys were thinking about them. And then they talk about treatment. And very often the medication, for board questions, the medication that you choose, they don't really care about. What they really want to know is that you know this slide. And so this slide has to do with what kind of treatment approach and in what order, at what age should you do it. So first we'll look at the preschool age kids. So these are 4 to 6-year-olds, okay? So there are no FDA approved extended release medications for this age group. So let that be a little clue as to maybe what we should be doing first. So all that you have available to you medication-wise is short-acting methylphenidate and short-acting amphetamine salts. That's it. And only the Adderall, the amphetamine salts, that's the only one that's on label. Methylphenidate is only approved at 6. It only has FDA approval at 6. So you only have this one medication. That's the only thing approved. So that can kind of tip you towards saying, I bet I'm supposed to do evidence-based behavioral therapy as the first line approach. And that would be the right answer. No medications with it, just evidence-based behavioral therapy. Now, those of you who have been in our area for a while or in any area practicing anything to do with pediatrics know that evidence-based behavioral therapy is like a unicorn. It's very hard to find. So we end up only having access to a couple of these. The ones that we have in our community is we have parent-child interaction therapy, or PCIT, that Dr. Warren does over in neuropsych. There's one community provider that does that as well, although they're like inside an agency and you can't refer directly to it. So you just have to hope they get chosen. Right, I know, great. And then there's another one that's called Triple P. And Triple P is kind of there are lots of people trained in Triple P kind of just out in the community. So even some of our bigger pediatric practices have like a nurse who's trained in Triple P in the practice. Triple P is like a very to the point problem-based behavioral therapy that works on like building a behavioral strategy with a parent to solve one individual problem. And then once that has improved, then we move on to the next one. So there is some access to that, but it's not like you can really put in a referral to Triple P. It's just like one that maybe the counselor chooses to use. So what we end up doing a lot is referring to a counseling group. And I would encourage y'all to actually write, I'm sending them for counseling for Triple P. That way they'll actually get paired with the person who's trained in the evidence-based therapy. So you'll see us do that a lot at different ages for different things. We'll put the referral to counseling, and then we may actually say the approach we want them to use, because that's the only one that's evidence-based. Whether that gets carried out, who knows, but at least you tried your best. So those are the ones that we kind of commonly have in our area. And most of our big counseling groups have somebody trained in Triple P, and lots of them actually have like Triple P trainers who are counselors. So that is something that we can access. Obviously, it's really hard to get parent buy-in with any behavioral therapy. Also, behavior always gets worse when you start a behavioral therapy before it gets better. That's the nature of how we are as humans. Like if you start to crack down on us in one area, we're going to push back. And if we can't do that same behavior by pushing back, then we'll pick up a new one that's worse, and we'll push back at you with that one. We all do that all the time, even as adults. And so definitely our kids do too. And so we need to prepare families that behavioral therapy is hard, but it's worth it. You really have to sell it in clinic. Otherwise, you can put in 1 million referrals and nobody will follow up with it. Then they also recommend behavioral classroom interventions. This one was actually a little bit new. This is the first time the AAP has really come out and said, if you're 4 to 6 and you have ADHD symptoms, you should be in the classroom. Because some of these kids are preschool age. And so this is saying you should be in the classroom, which as developmental pediatricians, we've always recommended that at 3 years old, you go into a structured school setting to learn some of those skills. But now you actually have it in a guideline. So that's really what you're supposed to be doing. So at 4, they should be going into school. And then medication only if symptoms persist despite therapy. So not only if symptoms persist because you couldn't find therapy, but only if they've already tried therapy. That's the official guideline. So that is the test answer, always, okay? The only medication that they recommend is actually methylphenidate. And they have a wonderful statement that I use on prior authorization requests, because our insurance companies love to say that they don't want to pay for methylphenidate under 6 because it's not FDA approved in that age group. But in this guideline, there's a wonderful paragraph that you can just copy and paste and put right onto the PA form that says that although the amphetamine salts have the FDA approval, that happened at a time when FDA approval was less stringent and rigid than it is now. And that since that time, there have been more studies about methylphenidate in this age group than amphetamine salts, and they by far are more evidence-based than using amphetamine salts. So methylphenidate first in this age group. If you've been on developmental peds, you'll notice that guanfacine is not mentioned here and how much we personally love guanfacine. So we are working outside the guidelines whenever we do that. So you will know that we do that in practice a bunch, but you will know that on your test, you don't write that, right? You always go methylphenidate. Then for our school age kids, 6 to 12, a combination therapy approach is what's recommended. So they say do the therapy and do the meds right from the get-go. So then you also get the benefit of you can do the extended release medications at that point. So once a day dosing that's going to carry them all the way through the school day. And at this point, they don't care what stimulant you choose. So whichever one, the answer will be whatever has behavioral therapy, a structured classroom setting, ideally even some like 504 plan or some kind of behavioral support in the classroom, and a stimulant. That's the right answer. And then for the adolescents, it's pretty much the same with a couple little changes. First of all, at 12, they feel like you really need to get the adolescent's assent. So you need the adolescent to say that they are also willing to take the medication. I'll be honest, I start that at like much younger, asking them if they'll say like, I don't like taking my medicine. Oh, please tell me why. What's going on? That's actually a better way to get side effect history from a kid than just to rattle off the list, is to say, do you like taking your medicine? Does your medicine ever make you feel bad? And then they'll say whatever they're going to tell you about it. If it's something you can solve, then you solve it. And then if they hate it and you can't solve it, then you talk to the parent like, maybe this isn't the best choice for your kid because it seems like it's making your kid miserable. And while I can treat symptoms, that doesn't necessarily treat long-term outcomes. And that's what we're going to talk about here in a couple slides about what's our real goal when we're treating ADHD. Is it to have a clean Vanderbilt form? Or is it for us to have great long-term functioning? Which I would argue it's the latter of the two. The other difference in adolescent ADHD treatment is that there's almost, or I shouldn't say almost no, there's very little good rigorous studies into what kind of therapy works for them. What we know is that cognitive behavioral therapy that we love for everything does not work for ADHD in adolescents. So you can send them to the counselor to go do some CBT. That's great for their anxiety, their depression, their substance abuse, any other issue that they have, but it's not going to have an effect on their ADHD symptoms. So what they do recommend is organizational training. I think we all know, like, when have you ever had a teenager with ADHD who got organizational training, right? But it does exist, and it is what would be most helpful to them. That's what's actually teaching them to structurally build habits that take care of that frontal lobe action that they're missing or that is hard for them, all that executive functioning. So sometimes we'll talk about it like using lists, using timers on our phones, getting them like a smart watch that will tell them, you know, I'm supposed to be doing homework now, 30 minutes in, I should be halfway done with my homework now, and keeping track of all of those things. That's what that evidence-based behavioral program would be. So I put an asterisk next to it because even the AAP in their guidelines says, yeah, but we know that this is not really available. So just in general about medication choices, we always start with the lowest dose and then we gradually titrate up. That's actually a key action statement from the AAP, so they want you to do that as well. And we know that stimulant response rates are actually pretty good. So 70% of kids will respond to a methylphenidate, whichever one you choose. It doesn't matter. Just pick a methylphenidate, 70%. It's pretty good on a first try. 90% of kids with ADHD will respond to stimulants in general. And these numbers, as far as I could tell, did not exclude kids based on comorbidity. So like we know in kids with autism, they only respond to stimulants 50% of the time. So your average kid with just plain ADHD, their response rate to methylphenidate is probably even high. I mean, to any stimulant, it's probably even higher than 90%. You're going to catch most of them with a stimulant. And then there is this group of kids, about 40%, who will respond to only one class versus the other. So like they'll only respond to amphetamines or they'll only respond to methylphenidates. And that becomes important when we look in just a minute. I'm going to just real briefly tell you like the basic strategy for how you pick what stimulant. And these numbers play into that. Oh, here it is. How exciting. So this does not have all the medications on the market, but this does have mostly what's covered by Medicaid, which is the world that we live in. So this is the way I organize stimulants in my own head. So if it doesn't work for you, that's fine. Find a way to organize them in your own head. But first, we're just going to look at the stimulants because that's obviously what our guidelines are really trying to push us toward. So there are the methylphenidates and there are the amphetamines. So a standard approach that you could do on every kid that would be fully acceptable is a kid comes into your office, you've done all the slides that we've looked at before, right? You've done the two, you know, you've talked to the teacher, you talked to the school, you talked to the parent, you've confirmed the symptoms, you've ruled out comorbidities. You can start any one of those methylphenidates first. If they fail the methylphenidate, you can try one from the amphetamine class, right? Just to make sure you're not getting one of those kids who is in that 40%. And then you can say, ooh, they're not responding to therapy very well. And we'll talk about what you do at that point. An even better approach would be to try 2 methylphenidates, then you go to the amphetamines, and then give up. So when we get a kid like from primary care who has gone through that process and has failed 2 methylphenidates and failed 1 amphetamine class, we're like, oh, perfect, this is one of our kids, because that's usually what we get. So don't be alarmed if like no meds are tried or only 1 med's tried. We get them, we try them on a med, it looks like it works, we're gonna push them right back at y'all because like, oh no, they're good, you can have them back. So that's really what we're looking for with complex ADHD, like rising to the level where it needs to be referred out would be after you've tried 2 methylphenidates and an amphetamine. Okay. Non-stimulants have a role. They mostly are used as adjuvant therapy, mostly, and that's kind of how the AAP guideline doesn't come out and say that specifically, but it very much suggests that they're best used as an adjuvant, particularly the alpha agonists. So you'll see us use a lot of guanfacine extended release, which covers 24 hours a day, hyperactivity and impulsivity, and you'll see us use it with a stimulant as well. There are some cases where you have to go non-stimulant. So some of our kids who have weird arrhythmias, a non-stimulant's a good option for them. I have a kid y'all have been taking care of with SVT that wouldn't break for like 5 days a few weeks ago. He's on guanfacine, so we would not put him on a stimulant. We don't need him to come see y'all again. So there are some situations where you might choose a non-stimulant, particularly because of that. Yeah.
These things are saying not that they fail in this.
Yes.
Is that because they just straight up don't get any clinical benefit, or also including because side effects?
Great question. Excellent. So what we mean when you fail a stimulant is either you have continued to go up on the medication, that gradual titration of dose, you've gone up either to the very maximum dose and still seeing no clinical benefit, or you hit a side effect. I would tell you in our kids, these little kids, it's because we hit a side effect. We almost never get up to the highest dose on them without hitting a side effect. So usually a side effect that we can't tolerate. More often than not, weight loss, because we're not eating, more often than not. Yeah.
If you get one of those like stories saying like anger outbursts or like crying, that was gonna do. Would you continue and do a second methylphenidate, or would you just switch classes to like that?
I would still probably do a second methylphenidate. Yeah, their delivery systems are different enough that that accounts for a lot of what we call rebound symptoms, the irritability and agitation as the meds wear off. So from one delivery system to the next, it really can change, even though you're going from methylphenidate to methylphenidate. Good question. So for primary care, the implications are that ADHD should be treated as a chronic disorder, which in your mind, knowing how the AAP loves medical homes and good care of chronic disease, they put ADHD in that category. So they feel like you need to have a strong medical home and you need to use the chronic care model, which means that you're serially following up even in between well-child checks. So I don't know that this would pop up, but this just seems to be something that they really keep coming back to over and over. So they might want y'all to really feel that responsibility for these kids. And then, like I mentioned before, I'm not necessarily trying to treat to have a clean Vanderbilt. Some parents will continue to score that Vanderbilt sky high, and their kid is doing so much better. They're like getting straight A's, they're like calm when they come in, like everybody has good things to say about them, but the parent is like still scoring them 54 out of 54 on that Vanderbilt. So we're not treating the number. What we're really trying to do is help with these long-term outcomes. So educational failure. So like I said, if the kid's doing great at school, then awesome, that's our real goal. Vocational underachievement is a concern. So like that's like the kid who smart enough to go to college, would want to go to college, but instead chose not to go to college because their ADHD symptoms were so bad and getting in their way. Like what a tragedy. Not that everyone needs to go to college, but if they wanted to, we want people to be able to achieve what they want to do and what they're capable of doing, and not letting their inattention get in the way. And then poor relationships. So in an adult setting, that looks like divorce, legal problems. In a kid setting, multiple referrals. Nobody will play with me at school because I hit them too much, and I might throw dirt in their eye, you know, those sorts of things. So this is the functioning that we're looking for. Mental health disorders. So there's an increased risk of depression, particularly for people who have ADHD. And substance abuse disorders. What we know, lots of parents are very worried that their kids are going to get addicted to the stimulants. I don't know if they ever say this to you, but they're very worried about this. And so actually what research has shown is that your risk of a substance abuse disorder in adulthood goes from being elevated if you have ADHD to being the average for all people if you're well treated with a stimulant and you have ADHD. So it's actually protective against substance abuse disorders. So it's a really good point to point out to parents who are worried about that addiction thing. Oh, you're worried about your kid being addicted to something. Awesome. Well, let's put them on a stimulant so that we can actually try to protect them from that. And that kind of blows a lot of parents' minds. To put their kid on a medicine to protect from that, but it works. And then you are actually at increased risk for early death if you have untreated ADHD as an adult. This happens to do mostly with like impulsive behavior. So there's more risk taking and more risky type behaviors. Yeah.
With I think it's a triple increase for car accidents.
Mm-hmm.
Do you ever talk to your patients about the effects of medication, like continued use even during summer for that teenage group?
Yeah, so I actually have parents write, like I make them, not make, I suggest that they write up a contract with their 15, almost 16-year-old that has a few rules. The rules are we don't drive without our stimulant ever, that our phone is in the trunk of the vehicle. I'm so mean, so mean. If you have ADHD, there's no way if that phone vibrates that you're not gonna look at it. They can say they're not going to, they're going to look at it. And so, yes, we make them put it in the trunk. So if they were in a car accident, they still have their phone. It's right there. It's just in the trunk. And we also have to talk about disconnecting it from like CarPlay or stuff, like so you can get real in the weeds. But those are the two big ones. You have to have your stimulant, and you can't have kids in the car. No other like teenage friends in the car. We're just trying to reduce distractions, and we do that for 1 year. The stimulant, driving on the stimulant, we would continue that, but then if they've done well, then maybe they can have a friend in the car after that 1 year. And then maybe I'll let the phone, I don't know, I just think I'd leave the phone in the trunk forever. Like, I just think that's probably best for them. They're so bad about it, so bad. So just real quickly, this is kind of the last slide with a lot of information on it. And that's about complex ADHD. So complex ADHD is like that's where developmental peds and psychiatry really shine. So these are the kids that we treat mostly. They either had onset of symptoms at younger than 3, which I know people look at me and they're like, you have some kids with ADHD who are 2? I do. They're mostly out of the NICU, to be perfectly honest. That's mostly where they're coming from. So they're coming to their ADHD in a little bit of a different way. It's actually like a truly like neurologic damage, CNS damage kind of way. And so sometimes we do have to help those little dudes out. Sometimes people were put on really long clonidine weans. The West Coast particularly does some of that. So some of the opioid babies are being put on these long-term clonidine weans. And babies' brains don't like to be bathed in clonidine. And we actually end up finding that then at like 2 and 3, we're having to start them on alpha agonists routinely because it's like shifted the receptors in their brain somehow. So I have a few of those now, actually. So beware of clonidine in babies. Also, complex ADHD includes those older than 12 who like, they were doing perfectly fine and now they're 12 and now we think they have ADHD. That really suggests that we're looking for something different in general, or that we just need to spend a lot of time digging out that history that people ignored or missed before then. Yeah.
Is that when you do your industry with the
I personally do not, but I think that it wouldn't be necessarily wrong. My issue with the urine drug screen in teenagers is I'm trying to get them to trust me and to build up, you know, kind of like a relationship with them. And it is really hard when the first thing I do is ask them to do a urine drug screen, because it's almost like saying, I want you to trust me, but I totally don't trust you at all. So for this kind of a thing, we would actually be looking a lot more into like your learning, looking into, yes, your friends, your connection to friends, looking for depression, looking for anxiety. Those at that point are actually more likely than ADHD. Substance abuse is certainly in there too. I would ask the psychiatrists what they do. Their answer may be very different because they actually get a little bit different patient population than we do. Most of our kids have a neurodevelopmental disability as well. They're just not quite as high risk for substance abuse disorders. So we don't have to have quite as high level of suspicion, but psychiatry does. So they may give you a different answer on their end. Yeah.
If you had a patient that came in and they were like 13 or 14 and they seemed like they'd had symptoms for a long time, is that still complex ADHD or is that just ADHD that was missed?
ADHD that was missed. Yep, they just have to show symptoms prior than 12. They don't have to be diagnosed prior to 12. But sometimes you'll really get these families and they're like, no, this just started. Sometimes those are also kids who like are in private school and it just really got hard. So now we have all these symptoms. So we have to do some real digging there to see if it's that expectation mismatch or if it's true ADHD and a really bright kid who maybe hadn't been challenged yet. We just don't expect that to be part of a general pediatrician's purview because we know you'll have like 10 minutes. So you're not going to tease that out in 10. So we may not tease it out in 40.
On that,
Yeah.
symptoms that have to be also causing impairment.
Yes. Mm-hmm. We probably give a little leeway on that, which is probably why America's percentage rate is up a little higher, to be honest. Yeah.
For impairment, like when impairment felt as being like it takes double the amount of time to the trial.
Yeah. Yeah, educationally, socially, or like emotionally. Yeah. Absolutely. They could have been working their tails off way more than they should have needed to. Mm-hmm. Then diagnostic uncertainty. So if you just have a kid and you just don't know, it just doesn't fit, doesn't feel right, send those. Poor response to treatment. And this is any kid of any age. So at any age, if you have diagnostic uncertainty, that's complex ADHD. Like if you're not sure if there's a learning disorder there or not. Poor response to treatment. So you've tried your 3 stimulants and now that's still bad. So that's a great referral. Severe functional impairment. So that's how I get those little tiny babies. That's how I get the 2 and 3-year-olds. First of all, by age, but then also because these are the calls that I get from like Dr. Greenhouse, like mom shopping in Publix, right? And I get this call and she's like, my office got torn up today. I'm okay, we'll see them. Because a lot of those doctors, like they see kids all the time. Like for them to be shocked by kids' behavior, you're like, ooh, they really must have done something good to your office today for me to be getting the phone call. And then concern for comorbidities outside the Pcp Scope. So this is kind of an interesting one. So some people come out of training feeling more confident about things like anxiety and depression than others. So if you get a patient and you're like, oh, they seem really depressed and anxious plus ADHD, I feel like I'm in over my head, feel free to send them. If you feel confident about it, it's within your scope of practice and go for it. And you can keep those yourself. So we do find like in our community, there are some PCPs who hold on to a whole bunch more kids themselves than others because they just feel more confident in that, and that's fine. And then you can refer to developmental peds or psychiatry. The main thing for us is that if you think that there's a learning disability or autism or some other neurodevelopmental disorder, we're the right people. If you think that it's ADHD and conduct disorder or ADHD and maybe like a personality disorder trying to cook up or something, maybe bipolar disorder, that goes to psychiatry. So that's a good way to rule them out. Yeah.
So for and like comorbidities. Right? That I'm going to put them on something while we're waiting for referral.
Yeah. Absolutely. Absolutely. Yep. Yeah, we'll never ding anybody for trying the stimulant. All right. Here are the references, including that fun AP guideline that y'all should be familiar with, which you kind of now are because you listened to my slides. And then we have just a few minutes. Any questions, particularly about like the medications? Yeah, go ahead.
So with medication,
when we were saying it's like 77% genetic, if there's another kid in the family that's on a certain medication, is like with like SSRIs and whatever that typically works, we can use something.
100%.
Okay.
Yep, 100%. Yep. Oftentimes they even need the same exact dose, or there'll be one dose off. So yeah, like if brother did well on Concerta, yes, start there. That's a great spot. Mhm. Yeah.
What is your opinion on it?
So I rarely recommend them if there's not a growth issue. So if there's a growth issue and we actually need that child to get more calories in on the weekend, then sure. It shouldn't matter, but my kids, when I ask them, like my big kids, if they take the weekend off, Mondays are terrible. They hate Mondays because the medicine just hits them harder on Monday. And if they take it every single day, they feel themselves the whole time without ups and downs. So I used to feel very differently about that. I used to feel like, oh, it doesn't matter. And technically it doesn't, but my feedback from my actual patients on the meds is that they do not like to go on and off, on and off, on and off. It gives them headaches. They feel more fatigued the first day that it's on. It shouldn't work that way based on the pharmacokinetics and dynamics. It should be in and out of their system, so it shouldn't matter. But it seems like it actually does. So I usually recommend that you give it every day. I'll say it's definitely not wrong to give it every day. If you feel really strongly that you don't want to give it on the weekends, then don't give it. But know that it may make your kid not feel very well on Monday. So ask your child if it bugs them. Also, a lot of my families could use the help of the stimulant on the weekend. So some of the most risky things that go on with my kids are on the weekends with their families. Because at school, you're just so structurally contained. They're only going to get into so much trouble, but on the weekend, that's when the kid's going to run into the street and get hit by a car. It's going to be on a weekend. It's very unlikely to be on a school day. And so having the stimulant any day for safety is very helpful. Now, for my inattentive ADHD type kids who just like aren't paying attention, sometimes it's not such a big concern because they're unlikely to like run into a street anyway. But usually we recommend every day, unless there's a growth issue. Yes. Oh, like 5 hands at once. Okay, we'll just go across the room. Go ahead.
Can you talk a little bit and how you decide which one to start with first, like specific problems that a child might be having?
Sure. So this is off of the guideline. They still say you should use atomoxetine, which is a kind of a joke in our group. We just don't feel like atomoxetine does anything ever, except give people mood swings. And so that's usually the last thing I want. You'll find that we use a ton of guanfacine extended release or intuitive, just tons and tons and tons of it. So we feel like, sometimes I feel like it should just be put in the water of the schools just to bring everything down a couple notches. Really nice side effect profile. So very few side effects, sleepiness, or maybe some irritability over time on a kind of higher dose. Generally really well tolerated, covers 24 hours a day. So usually what you'll see with us is that it's guanfacine extended release. Now, if they can't swallow whole, because you have to for that, you can do guanfacine twice a day crushed. It doesn't work quite as well, but it does the same sort of thing. So guanfacine is almost always the one we choose. Clonidine, super sedating. You'll see us use that, but usually in kids who have like genetic syndromes or something where their hyperactivity is through the roof and they can tolerate all that sedation, but the average kid can't tolerate it. So guanfacine is usually our go-to. And you will see that of the developmental peds patients that we follow with ADHD, maybe 40 to 50% are on a stimulant plus guanfacine extended release. It's very, very common in our practice. Over here, there were a couple hands. Yeah.
So she started doing this
Yes. I have not been able to convince a family yet. I've tried. I've tried a little bit because I'm curious about it. It seems good on paper. It's similar, so it's Vilavaxine, I think. Oh, I have it on a slide back somewhere. Yeah, it's Vilavaxine or Zaxine or something. Anyway, It is an SSNRI. Yes, viloxazine, yes. So it should help with anxiety as well as ADHD. That was the promise of atomoxetine, and it doesn't do anything. So, so hopefully this one does something. It looks better. They did do it head-to-head with atomoxetine and it outperformed atomoxetine. I have not yet seen a study where it was head-to-head with methylphenidate, which is the gold standard study, is a randomized control trial head-to-head with methylphenidate. Many of the adjuvants do not ever do that study because they can't outperform methylphenidate and they kind of know it. But I keep asking their drug rep to bring me that study, and I keep getting animal model studies about binding and things. I don't know. So I have a little bit of apprehension about how well it will work, but I'd love to try it, but none of my patients want to be the first. I'm really honest with them. I'm not going to tell them, oh yeah, prescribe this to 12 people. I've not prescribed it to anybody. So I've told them it's a new medicine. It may be really promising, but I haven't gotten anyone to bite on it yet. Sure. Sure. Yeah, it's actually covered now. I think Select Health. It's like some of the Medicaid companies have made deals with them, so you actually probably can get your hands on it right now as easy as you ever will. It came out after the AAP guidelines, so it's not in play for that. But yeah, I'm interested to see how it works. Hold on a second, Keith. Keith, did you have a question? Okay. You good? Yeah, go ahead.
I guess this is more like a side view with the, when I have to like an SNRI has a couple of them and like can't be helpful for like ADHD and got some comment question. So they have 5 or 4 plans and IEPs for preschool.
Oh yeah.
Oh, okay. What
Yeah.
age does that start?
3 years old. Yep, when you enter the school district at 3. So before that, you have this thing called a IFSP, family service plan, individualized family service plan. There you go. What's the I? And that's like IEP for babies. And it is all services in the home. And then at 3, those services shift to the school, and that's when you get the IEP or 504. And yeah, and bupropion, while it's used quite a bit in adults for ADHD, we don't use it as much in kids. It's definitely off-label in kids. But some people do. We just don't use much of it in developmental peds. But we also refer some complex ADHD out to psychiatry. So sometimes we also get in over our heads and send out. And that's more when you're going to start seeing some of those meds coming out. Excellent. Any other questions? No. Wonderful. And this big ADHD guide you can get from ADHDmedicationguide.com. It is free. And this is the newest one that has like a gazillion new meds because a whole bunch of ADHD meds just came out. So if you're ever looking to switch between equivalent doses, that's how this chart is set up. It also just kind of shows you all the different options. Most of these aren't covered anymore by Medicaid. Yeah, so probably the real answer is supposed to be 2 weeks to 30 days, 15 to 30 days. That's what the insurance companies want you to do. So sometimes they won't cover a different one. Like they'll make you wait 15 days to get the next fill, or 30, depending on which Medicaid you are. But in our clinical practical world, I mean, it's an immediate action medication. So I tell families 3 to 5 days. So if I can get them a different dose that fast, I will. Especially when you're first starting. Like if you're starting in a 12-year-old, like a pretty big sized kid, and let's say you're starting, and we'll pick something easy. So you're starting Ritalin LA at 10 milligrams. It's this big kid, almost about to go into puberty. So probably with a pretty fast metabolic rate, but the recommendation is still to start them at 10. You don't guess. So his dose might need to be 50. I'm not going to make him wait 5 months to get to the dose that he needs if it's clear that it's not working. So, like a week, see how it goes. If he's tearing classrooms apart and on day 4, he's still tearing classrooms apart, I'm definitely going to say go to 20 that fast, if that helps. Cool. Thanks, guys.
Thank you.
Anytime.
Thanks for